Good evening, viewers. Welcome to the session 2 of Diabetes Essentials of season 2 with Dr. Sanjay Kalra sir. Dear viewers, these online modules are an educational initiative from Enerzal Zero and in memory of Dr. K.K. Agarwal sir. In last session, Dr. Kalra sir took us through setting up a diabetes clinic within limited resources. And today, he will take us through the new session on glycemic targets 2022 update. For many people with diabetes, glucose monitoring is key for achieving the glycemic targets. And overall, regardless of the population being served, it is critical for glycemic targets to be woven into the overall patient centered strategy. So, before I hand over the platform to Dr. Kalra sir to take us through today's module, let me have the opportunity of announcing the names of those doctors who have answered the first session's quiz questions correctly. And the names are Dr. Lakshmipati Bhupati from Tamil Nadu, Dr. Santanu Kumar Bhattacharya from West Bengal, and Dr. Hitesh Vora from Maharashtra. Dear viewers, we started this second season with an international module with Dr. Vivian Fonseca and Dr. Sanjay Kalrasar moderating the session on a scientific approach to improving vascular and metabolic health in diabetes. If any of the viewers want to watch this session again or have missed this, to go through the session, it is available on the same platform, the same tab which you are connected right now. With this, I hand over the platform to Dr. Kalra sir. So over to you.
Thank you, Rahul, and good evening, friends. Like every Sunday evening, it's a pleasure being with all of you. It's a pleasure sharing and learning from each other, sharing and learning about how to manage diabetes. Last time, we spoke about how to create a diabetes care setup with limited resources. Today, we'll speak about the targets that we have to share, that the targets that we have to achieve. And our reference for today is the American Diabetes Association Standards of Care 2022. Now, many of you do ask, which is an easy book that I can read for diabetes care? I would suggest two favorites of mine. The first one is uh, Practical Diabetes, edited by Professor Nitin Kapoor from Christian Medical College. It is available from JP Publishers. But please don't buy the book because I think in a month or so, a new edition is going to come out. So that would be my first choice any day. And the second one would be, to remain update, ADA, American Diabetes Association, Standards of Medical Care, SMC 2022. This is available free of cost. You can download it. It is all published in different chapters, as different chapters in diabetes care. Let's talk about glycemic targets. Now, whenever we embark on a journey, we have targets, we have a destination. We know where we are headed. Whether you want to go to Delhi or Mumbai or you want to fly to London, you know where you are going to. The Rig Veda says, the truth is one, but the paths to it are many. So, how do you assess whether you are traveling to Delhi or Mumbai in the right manner? You look at the milestones on the way, you look at the notice boards on the way. Similarly, in diabetes care, we know where we are headed. We want good glucose control. Not only good glucose control, we want safe glucose control. So we want to avoid hyperglycemia, achieve euglycemia, and prevent hypoglycemia. And to ensure that we are on the right path, we assess ourselves. We assess ourselves in various ways. We can do that by checking HbA1c and by self glucose monitoring. SMBG means self monitoring of blood glucose. But CGM, continuous glucose monitoring, is playing an increasingly important role in diabetes care now. Under the heading of CGM, we have two types. One is CGM, continuous glucose monitoring. This is done for up to 5 days. A sensor is placed and you check the interstitial glucose values. The lead company in India is Medtronic. Another method is AGM, ambulatory glucose monitoring. It is also known as flash monitoring, and here the provider is Abbott. But in general, to get a snapshot of the kind of glucose control we are giving our patients, we do HbA1c. HbA1c should ideally be done from an accredited lab, NABH accredited lab, and the ideal method is HPLC, high performance liquid chromatography. In your stable patients, you can check HbA1c twice to thrice a year also, but it must be done at least 2 times a year. This is in patients who are at goal, who have stable glucose control, who don't have any symptoms, or where the clinical profile or symptomatology is concordant with the fasting and postprandial glucose, which is in turn concordant with HbA1c. So everything is in tune with each other, is stable, then you can reduce the frequency of assessment. But if you have patients where there is lack of glucose target achievement, where there is anticipation that the target may not be achieved, or where there is expectation that the target may be achieved, then you would want to check glycemic status more frequently, at least quarterly. Note the term at least quarterly, that means 4 times a year. Many times in my OPD, I check sugars regularly and I check HbA1c after 6 weeks. Why do I do that? Somebody comes with an HbA1c of 18.9, 15.2, very high glucose levels. I want to know whether I'm on the right path or not. So I will check after 6 weeks. Someone with vague symptoms, the symptoms are not matching with the self monitoring of glucose. The self monitoring of glucose is not matching with the HbA1c. I'm not sure whether I'm on the right path or not. Again, I can check at 6 weeks. A very demanding patient, someone who is fussy, I can check more frequently. Someone where the stakes are high, pregnancy and diabetes, renal transplant and diabetes. We really want tight control, and there is no excuse not to have tight control. Then we can check HbA1c more frequently. In pregnancy, in fact, you can even check at 28 days or 30 days interval. So this is about HbA1c. Just like we say that diabetes care is individualized, diabetes management is individualized, you can also individualize the frequency of assessment. Like I said, you can also do CGM, continuous glucose monitoring, or AGM, ambulatory glucose monitoring. It's important to monitor because if you monitor properly, you will achieve your targets more frequently. And a term that is being used now is time in range. So this is the kind of picture that you will get from a standard AGP report, a standard flash report. Look at the lines. The green shaded band is the target range. In this patient, the target has been set from 70 to 180 milligram percent. So we'll find that much of the time the patient is in green range. But there are times, and if you look carefully, this is early in the morning, in the wee hours of the day, the patient is in red zone, that is hypoglycemia. And there are times when the patient is in orange or a beige kind of a color. This is above range. So looking at this graph, the one in the middle, you see that the chances of hypoglycemia there early morning, maybe starting at 2 or 3 a.m. and going on up till perhaps 9 a.m. After 12 p.m., that's known, and then after 8 or 9 p.m., there is a risk of hyperglycemia. Perhaps this coincides with lunch and dinner that we need to find out from the patient's diary. Let's look at the bottom bars, the 2 bars. These are daily glucose profiles. So each tiny section is one particular day, Sunday, Monday, Tuesday, Wednesday. And here you can see each day and you can correlate these ups and downs, these peaks and troughs with the meal pattern and with the exercise pattern, physical activity pattern or stress levels on that particular day. But the graph at the top tells you about TIR, time in range. So we see that 46% of the time our patient was in range. The target range was set at 70 to 140. We can change it manually if we wish. 44% of the time, which is unacceptable, the patient was in hyperglycemia, and 10% of the time the patient was in hypoglycemia. Within that, 5% of the time the patient was in very low hypoglycemia. So this is not acceptable. You can also see the glucose variability that has been calculated. It's 45.5%. So the average glucose is 175, not so bad, but the glucose variability is very high, nearly 50%. So all these numbers, all these matrices, they give us different ideas. There are new terms that are used now. Apart from time in range, we have time above range and time below range. Time above range is classified as level 1 and level 2 hyperglycemia. These are new terminologies that I am also getting used to slowly. But level 1 hyperglycemia means between 181 and 250 milligram. Level 2 hyperglycemia means above 250. There is a classification of hypoglycemia as well. We'll discuss it in detail later on. There are 3 levels, but let's mention this here. Level 1 hypoglycemia is when glucose is between 54 and 69 milligram percent. Level 2 is when it's below 54. Level 1, level 2 hypo and hyperglycemia are issues to be avoided, but level 2 hypo and level 2 hyperglycemia must be specially avoided. Suppose we don't have access to ambulatory glucose monitoring and we have just HbA1c with us and self-monitoring of glucose or lab monitoring, then also we have recommendations. Here our goal is an HbA1c less than 7. Note, it is not just 7, it is less than 7. And the Japanese guidelines very clearly say that you should bring it down as low as possible without causing hypoglycemia or harm to the patient. The preprandial glucose should be between 80 and 130, and the peak postprandial should be less than 180. So average about 100ish preprandial pre-meal and less than 180 post-meal. Coming back to the classification of hypoglycemia, we'll repeat level 1 less than 70, level 2 less than 54, and level 3 a severe event characterized by altered mental and or physical status requiring assistance from a third party for the treatment of hypoglycemia. So if you need help even to take a glass of water, that is also a level 3 hypoglycemia. Whenever you speak with your patients, whenever they come for their clinical encounters, clinical visits, review a history of hypoglycemia. I would very strongly suggest something known as the Hypoglycemia Awareness Questionnaire. This is published in the Journal of Pakistan Medical Association, free to download. Just go to Google Images Hypoglycemia Awareness Questionnaire, and you will see a list of 10 questions which you can ask each patient. So in the last 1 week, have you experienced any of the following? That's what it is. I use this questionnaire myself for all patients on insulin and all patients on high-dose sulfonylureas. If your patient does experience or suspect hypoglycemia, preferred treatment would be glucose. You can give a glucose drink, a juice, a sugar cube to be kept in the mouth. If this doesn't work, subcutaneous glucagon can be used. Now, earlier I used to stock glucagon in my pharmacy. This is when we used to use the older insulins, bovine and porcine. Hypoglycemia, severe hypoglycemia was very common. Now it's not all that common, and I do not stock glucagon because number one, the injection is expensive, about 1200 rupees. Number two, the shelf life is very short. So usually these injections expire. But if you have someone with type 1 diabetes, someone with hypoglycemia unawareness, someone with frequent episodes of hypoglycemia, someone on insulin, someone with renal failure, autonomic neuropathy, that person should keep injection glucagon in his or her kit. Repeated episodes of hypoglycemia and or hypoglycemia unawareness should trigger education, focus more on diet, exercise, regularity of lifestyle, focus more on dose adjustment, hypoglycemia awareness training, and on prevention and management. We can also change the glycemic targets. So you don't necessarily have to try for a glucose of 70 or 80 or 100. You can be happy with 150, 200, 250. The first aim would be to avoid hypoglycemia. The second aim would be to avoid hyperglycemia. And of course, focus on cognitive function, endocrine function as well. See if the patient has got any pituitary, thyroid, or adrenal disease, three endocrine disorders, and see if the patient has got any renal, hepatic, or gastrointestinal disease. So focus on these three medical and three endocrine conditions to see the reasons for hypo. So these are the targets that we focus on. But let's ask our questions for today. And our first question is, on the basis of provider judgment and patient preference, that is your judgment and your patient's preference, achievement of HbA1c levels lower than 7 may be acceptable, may be beneficial. Is this true or is this false? So first question is, if you have an HbA1c less than 7, is it acceptable or beneficial? If your judgment says that and if your patient wants it, true or false? Second question is, when you see an AGP report, ambulatory glucose profile, which of these is not available to providers and patients? Is it GMI? Is it data on TIR, time in range? Is it hypoglycemia and hyperglycemia or risk of diabetes? Which of these is not included in an AGP report? GMI, TIR, hypo and hyperglycemia, risk of diabetes. With this, we come to the end of today's talk. Let's see all the questions that have come. Dr. Nishab Khan says, guide on type 2 diabetes and thyrotoxicosis. These are commonly associated with each other. In thyrotoxicosis, it is very difficult to control diabetes. So you will find hyperglycemia. As you create euthyroidism, as you use maybe carbimazole or methylmercazole, you will find that actually glucose levels will come down. If you have a patient who is severely hyperglycemic, severely thyrotoxic, and in a catabolic state, it would be a good idea to give insulin for a short period of time. You do not have to give insulin forever and ever if it is type 2 diabetes. You can counsel the patient that, your vehicle has kind of skidded off the road. You are losing weight. Let us give you some insulin just to bring you back on target, bring you back on the road. Once you gain some weight, once you feel better, then we will de-escalate and we'll shift you to tablets. This is possible in the vast majority of patients. Dr. Ashok Kumar Sharma asks if TIR is the best indicator. That is yes, Dr. Ashok, it is the best indicator. Problem is if it is available. So if you are able to access ambulatory glucose monitoring, flash monitor, and also your patient is able to afford it, then certainly TIR is good. If not, SMBG and HbA1c will do the trick for you. Dr. Dinesh asks about the new target for fasting glucose. So ideally, Daksab, it should be below 100 in everyone, but in pregnancy, it should be below 95. If your patient is elderly, then fasting glucose of even 130 is acceptable. Dr. Pradeep Patru asks about target HbA1c as per period of diabetes. So in the average adult, it is less than 7. In pregnancy, try to bring it as low as possible. And when will you relax the targets for HbA1c? That is in patients with long-standing diabetes, patients with chronic complications of diabetes, especially microvascular, especially neuropathy and nephropathy, especially autonomic neuropathy, and especially autonomic failure or hypoglycemia unawareness. In such cases, HbA1c target should be relaxed. When should we tighten the target for HbA1c? That is, if a patient has a disease, a medical, a surgical, or an obstetric disease, which will resolve only if you give tight control. Maybe septicemia, tuberculosis, diabetic foot. Then we want to bring the HbA1c as low as possible. And Dr. Anshul Singhai from Bhilai adds to this that septicemia could be a cause of hypoglycemia. That's right, Dr. Anshul. Septicemia can cause both hypo and hyperglycemia, both of them. And sometimes in septicemia, actually, because there is adrenal failure, that is why we have hypoglycemia. And Dr. Anshul points out that TIR is actually not standardized across the world. There are guidelines. Even I am author of one of these guidelines where we have tried to standardize the TIR, the time in range target, for elderly, for young, for pregnant, for those at risk of hypoglycemia. But because it is not used frequently, especially in India, because of the cost, that is why you will find that very few reports and very few diabetes care professionals speak to each other in this language. We are more comfortable speaking in the language of HbA1c, which is standardized. Dr. Ashok Sharma says, what is the best target index? So each of them is important. There is something known as the glycemic pentad and the glycemic sixer. Glycemic pentad says that we should try to control fasting, postprandial, and HbA1c while minimizing hypoglycemia and glycemic variability. So, like in the hand, all five fingers are different, but all are equally important. Similarly, all these five are equally important. Glycemic hexad or glycemic sixer has six targets: minimize fasting, PP, and HbA1c, minimize hypoglycemia, nocturnal hypoglycemia, that's the new one, and glycemic variability. All six are independently linked with adverse cardiovascular outcomes. So that is why they are listed in the glycemic pentad and hexad. Time in range guidelines, I would suggest that we read either the ADA, American Diabetes Association Standards of Medical Care Guidelines, and let me give you the reference for this, the one which I have written, and that is the easiest one to understand and read. There is an article, The Glycemic Compass, Time in Range. This is 2021, Kalra et al., Journal of Pakistan Medical Association, 2021 February. We use TIR as a glycemic compass to guide us in therapy. We also call it a theranostic tool. It is not only diagnostic, it is also therapeutic. Another good reference is individualizing TIR goals, individualizing time in range goals in the management of diabetes and role of insulin. Clinical insights from a multinational panel. This is published in Diabetes Therapy 2021. Individualizing time in range goals, multinational panel 2021 diabetes therapy. So these are two good guidelines to use. Dr. Anshul says that SGLT2 inhibitor must be avoided in HHS, hyperosmolar coma, non-ketotic coma. That's right, because there is a possibility of euglycemic ketosis. That is true. Any patient who is acutely ill, it is a good idea to avoid SGLT2 inhibitors. Whether it is acute kidney injury, acute heart failure, acute metabolic dysfunction. Anyone who is stable, has a chronic stable disease, chronic stable heart failure, chronic kidney disease, stable, then the drug will be helpful. NAFLD, it is helpful. But in acute liver disease, it will be harmful. Dr. Ashutosh Das mentions a point, acute diffuse thyroiditis, okay, acute thyroiditis or subacute thyroiditis with type 2 diabetes, sugar is high, increase in antidiabetic causes severe sweating, that's correct. So the sweating can be because of thyroiditis per se, it can be because of heat, it can also be because of hypoglycemia. So patient is already on vildagliptin and glimepiride. What we can do in such a patient is, first of all, control the thyroiditis. For sweating, it would be a good idea to add beta blocker. From folk remedy, what I tell my patients is to take alum, ALUM. The Hindi word is fitkari. So alum is available as a 10 rupee, a small 10 rupee, it's like a soap, a small square, and you just dip it in water and you apply it over your palms and soles. It actually reduces sweating. So fitkari or alum or aluminum hydroxide, local application, beta blockers, and good control of diabetes. The choice of drugs, if patient is very catabolic, then insulin should be used. If patient is not all that catabolic, then we can give sulfonylurea and vildagliptin, like you're saying. We must add metformin, don't forget that. And if patient continues to complain of sweating or uneasiness, then we reduce the dose of glimepiride. Instead of giving glimepiride 2 milligram OD, we might try to give glimepiride 1 milligram BD, Dr. Das, and that will also help. So that's actually uh, the questions that were asked. And I'd like to thank everybody, Dr. Ashutosh, Dr. Anshul, Dr. Ashok, Dr. Dinesh, Dr. Pradeep, and Dr. Nishab Khan for their comments and also for their kind wishes. We are also approaching the end of the holy month of Ramzan, and I'm sure Dr. Nishab would have just finished his iftar meal and then joined us. So thank you, sir, for sparing time for us. This brings me to a discussion on Ramadan and diabetes care as well. Now, ideally, we should begin preparation for Ramzan about 2 to 3 months before the holy month starts. By now, all the patients would already have been attuned to their management, whether good or bad. But still, at least one Friday is left. And there will be some patients who will say, Daksab, I want to give it a try. At least one Jummah, I want to fast. In such patients, an easy idea would be you reduce the dose of the morning sulfonylurea by half. So take that sulfonylurea, half tablet, before suhoor, before sahri meal. All the other medicines you can continue. If patient is on SGLT2 inhibitor, empagliflozin, canagliflozin, dapagliflozin, you can shift that from morning to night. So patient can take it after iftar. Time in range has not been studied during the Ramadan month, but I'm sure as research continues, we will have data and suggestions on that as well. But there are fatwas and there are guidance from the ulema, from the religious leaders, which say that you can do glucose monitoring during the fasting period. And you should do, because that is a way of taking care of your body. Dr. Sanjay Marathe says, okay, so good question, and let me take this. RBC life is 90 to 120 days. So usually in a stable patient, you will do HbA1c once in 3 months. But when you look at the HbA1c, the weightage is such that 50% of the HbA1c value comes from the glucose control in the past 28 days. And the rest 50% comes from the glucose control in the preceding second and third month. So routinely, we will not do HbA1c more than 4 times a year. It is only when we are concerned. Either I want very tight control, or I just want to be sure that I'm headed on the right path. Let us say my patient had an HbA1c of 9.7. I think the patient needs insulin. Patient says, Daksar, give me one chance. Let me try tablets. So, okay, let's try, but you have to focus on your diet and exercise. So that is a discussion. And then we say, how will we know that you're on the right path or not? Let us do an HbA1c after 6 weeks. If it comes down, fine. If it doesn't come down, we shift you to insulin. So you do that negotiation first. And then if the HbA1c comes as, let us say, 8.7 or 8.5, then you know you're on the right path. If it again comes at 9.5, 9.6, then you can more strongly motivate your patient to take insulin. A question is, can we use SGLT2 inhibitors with antihypertensive drugs? The answer is yes. Can we use it with diuretics? Now, usually the answer is less. If the patient is on a loop diuretic like furosemide or torsemide, that dose should be reduced to half. Chlorthalidone, hydrochlorothiazide, though they are potent diuretics, usually we don't have to reduce the dose, unless it is a very hot summer month, and then you may have to reduce them. And Dr. Hiteshwara points out rightly that alum or aluminum hydroxide can be used for non-diabetic patients with excessive sweating. Alone, it is not very effective, but you will find that these patients, they are very upset with life and you have to keep them busy. So if you help them, so see, Dr. Hitesh, now let us say someone comes to me and says, Doctor, give me a medicine for diarrhea. So I write maybe antiprotozoal. And then the same patient comes to you and Dr. Vora says, take this antiprotozoal, but also remember to take 250 gram or 300 ml of curd or yogurt every day. Also, remember to make sure that you get your RO or your water filter serviced. And also, make sure that you don't go and eat street food in the hot summer months. The chances of infection are very high. Now, no prize for deciding which doctor will be considered better by the patient. So I gave only a tablet. I did by medical dharam. But Dr. Hitesh Vora, he gave the tablet. He fulfilled his professional dharam. He also gave a folk medicine, which is curd or maybe banana. And so he demonstrated to the patient that he knows traditional wisdom as well as modern medicine. And then he also spoke about prevention. Today I am curing your diarrhea, I am giving you medicines, but I want to prevent your diarrhea tomorrow. So why don't you fix your water supply? So certainly the patient is not going to come back to me next time. She will go to Dr. Vora. And not only her, her friends and her sisters-in-law, they will also go to Dr. Vora. Dr. Deepak Gore, thank you for your kind words. And a very important question coming from Dr. Biswas. Yes, sir, pioglitazone should be avoided in diabetic macular edema. So we should avoid pioglitazone in patients with macular edema, with proliferative diabetic retinopathy, especially sight-threatening diabetic retinopathy. My favorite diuretic is a very old one, Anshul. It is indapamide. So, diabetes essentials usually avoid using trade names, but I take only one medicine. I take it for hypertension, a very light one, Coversil Plus. That has got indapamide plus perindopril, and I like it a lot. And Dr. Sarosh Ahmed Khan, thank you, sir, for your kind words as well. Diabetes Essentials is a success because of all of you, because of all of us. We work together as one family, one country, and we have only one aim, that is the health and well-being of all our countrymen and women. Dr. Ashutosh asked me what my favorite beta blocker is. So let us talk about the indications for beta blockers. Now, beta blocker is usually not used as an antihypertensive these days because we have better drugs. It is used as an antihypertensive in pregnancy. There, my drug of choice would be labetalol. Beta blocker can be used as a treatment for angina. There, it would be metoprolol, best drug. And for heart failure, there, my choice is bisoprolol. We also use beta blocker to reduce the tachycardia in Graves' disease. Again, we can use propranolol and bisoprolol. I used to use more of propranolol earlier, but the chances of spasm, asthma, cough, these are more. And during COVID times, I shifted to bisoprolol. Another drug you can use, which has minimum contraindications to reduce tachycardia in Graves' disease, that is ivabradine. Ivabradine is very safe to use, 5 milligram OD or 2.5 milligram OD. It will correct the tachycardia, and there is hardly any contraindication. You just don't need to worry. Do remember, giving beta blocker and verapamil together, or giving beta blocker and ivabradine together is contraindicated unless the specialist cardiologist is doing it, but then he will have a reason for that. But I would avoid giving both together. Indapamide dose would be 1.5 or 2.5 milligram once a day with breakfast. A very mild diuretic. It is not a thiazide diuretic. It is thiazide-like diuretic. So at the most, patient will have to go to the bathroom just once extra. When you give diuretic or when you give SGLT2 inhibitor, no harm in telling your patient, you may have to go to the bathroom once or twice extra from breakfast up till lunchtime. But your evening and night time will be better. You will have to go less frequently to the bathroom. If, however, you happen to be maybe a traffic policeman or maybe a school teacher, or you have such a busy job that you feel you just cannot afford that, there's no harm in taking the diuretic with lunch as well. No harm in doing that. Dr. Sarosh Ahmed Khan points out that even GLP-1RA like semaglutide should be avoided in advanced retinopathy. This is correct. And also in advanced retinopathy, don't be very aggressive in controlling glucose. Any kind of aggressive glucose lowering therapy, if you do it very fast, can cause some blurring of vision, can cause worsening of retinopathy, but this will be transient, it will recover. However, patient will complain. Even when you put a patient with very poorly controlled diabetes on insulin, even then they complain of blurring of vision. So we tell them, when you have to do a reality setting, expectation setting. So we tell them, madam, I'm starting insulin. Within 1 to 2 days, you will feel much better. You will have an anabolic effect. Bhai sahab, madam will begin to smile in 1 or 2 days. So that smile, how long has it been missing? How many days, how many months has it been since you've been making the morning tea? So then there's this wry smile. So don't worry, Madam's smile will be back in 2 days. She'll feel better. The postprandial glucose may come down after a week or 10 days, and the fasting glucose may take 10 days to come, 15 days to come down. In between, there may be blurring of vision. It doesn't matter, it will pass away. So if you can just set this expectations in advance, that preempts and prevents the patient from coming back and fighting you or arguing with you next week. So first, anabolic effect and happiness. Second, usually postprandial glucose. And last, usually fasting glucose. Usually that is how it works. But this might change depending upon the insulin regimen that you are using. So these are some other things also that you can do. Along with target setting, you should have expectation setting. Sometimes patient will come and say, I've been taking your medicine for 10 days, glucose hasn't come down. But are you feeling better? Yes. So madam, see, last time you couldn't even speak. You were so tired. Now you're able to speak. And from inside you, you feel the patient is argumentative, is arguing with you, but you say such a wonderful, such a masculine voice you have now. You know, so this is because of insulin. It's insulin speaking. So you relax, glucose levels will come down. And then you can explain the rules of driving. See, we've just begun driving. We've just set the car in motion. It's just first gear now. Now you come back. Let me go to second and third gear. We'll gradually increase uh, the gear, and we'll increase the pressure on the accelerator, and you will feel much better. So this is the way to handle patients. We also have various comments, and let me take them one by one. So thanks to everybody for logging in today. And Dr. Deepak Gore, thank you for your messages as well. And Dr. Rajdeep as well, thank you. So Diabetes Essentials exists because we all work together as a team. And I would, now that COVID is hopefully going away, I would love the opportunity to meet all of you in person somewhere, sometime. We never know. Dunia bahut choti hai, it's a small world, and I'm sure we'll meet each other sooner or later. So with that, I'd like to thank you and hand back to Team FDC. We need to unmute Mr. Basu. Unmute. No. Mr. Basu's, I think it's okay now. No. Today, Mr. Basu's system has got hypoglycemia.
I can hear you, sir, now.
It's good to see the FDC team, sir. Yeah, you're back now.
Sir, thank you very much for the session, because we really felt that you have taken all the questions and you have read all the suggestions as well, and we never felt that it's a virtual CME. We really felt that you are taking a CME in our home today, because in such a simple topic, you could give us latest updates. Now we all are now aware and kind of will start practicing the tier 1, tier 2, level 1, level 2 of hyper as well as hypoglycemia. And for the question answer, sir, you have taken almost all the question beyond the session and coming sessions as well. So that's why, sir, we say that all our viewers have really become addicted. That Sunday night, 9 p.m., we just cannot leave Dr. Sanjay Kalra, because all my queries and all my questions can be asked, and he will definitely answer all the questions, even single question and single comments. He takes it up. For this, sir, we just cannot give you enough thank you. We can just say that, sir, as many as sessions we can be having with you, sir. That's what we are looking and longing for, sir. Have a good night, sir. Jai Hind.
Jai Hind.